Hello, let's talk glomerular diseases number 2, the nephrotic syndromes, then a little bit of membranoproliferative glomerulonephritis, which can swing either way, and then a little bit of IgA nephropathy, which is not really a nephrotic syndrome, more so like fulminant hematuria. What are we starting with here? Well, remember glomerulitis, inflammation of the glomerulus. What's the glomerulus? The capillary bed that sits within Bowman's capsule. It's the vasculature of the kidney and the transitional point from blood to the renal tubule, which is filtrate. All of these disorders are named for what they look like, really. Most of these disorders are. Like membranous nephropathy. You see a ton of membranes. Minimal change disease. It's called that because you look at it under a light microscope and the glomeruli are normal, but the patient's got bad kidneys. And so it's like, oh, well, there's some really minimal change in these glomeruli. Hey, focal segmental glomerulosclerosis. By now, you know sclerosis. That means something's thickening or hardening. And we've seen arteriolosclerosis, which is like a concentric thickening of the walls of a blood vessel. Well, that's what's going on in focal segmental glomerulosclerosis. Remember, focal means that not every glomerulus is offended or injured. Some glomeruli are still healthy. And then segmental means that within any individual injured glomerulus, you've got some patches of damage and then some healthy patches too. And then HIV-associated nephropathy is a subvariant of focal segmental glomerulosclerosis. Specifically, it's the collapsing variant. So you need to know that one particular subtype of FSGS. Then we've got membranoproliferative glomerulonephritis, which is about the same thing as membranous nephropathy. That's membranous glomerulonephritis, except that proliferative part means that there's a high degree of hypercellularity that we see whenever we visually observe the glomerulus. And then IgA nephropathy lights up with an immunostain for IgA. So every single one of these diseases really is going to be based off of what do you see when you look at the glomerulus. Very, very visually involved. You have to know that these words are just adjectives. They're corresponding to adjectives to describe how the thing looks. Let's get into membranous glomerulopathy. You're going to see subepithelial deposits on electron microscopy. And when you look at it grossly under a light microscope, you're just going to see a bunch of thick membranes in an otherwise normal glomerulus. So let's look at it before we go any further. Here are these subendothelial deposits on electron microscopy. Remember, how are we going to read or interpret any electron micrograph? Well, step one, find the basement membrane. So here's our basement membrane. You can tell that it's this big, thick strip here. Step two, which way is it curving? Because you know that everything on the inside of the basement membrane is going to be your endothelial side. And then everything on the outside of it is going to be your epithelial side or your podocyte side. And so when we say that we've got subepithelial deposits in a membranous nephropathy, what that means is that there are immune complexes, as in type 3 hypersensitivity, Johns, that are being pressed across the basement membrane, but not past podocytes. And so where these antigen antibody complexes deposit is between the basement membrane and podocytes. So we're going to call it a subepithelial deposit because the podocyte is an epithelial cell. And remember that if we flip-flopped it, if we said that the immune complex is between the capillary endothelium and the basement membrane, that's a subendothelial deposit. So how do we ID that visually? Well, identify the basement membrane. If the complexes are sticking out of the outside of the basement membrane, you know that it's going to be subepithelial versus this would be a subendothelial deposit if the complexes were pointed inwards towards the center of the lumen of this capillary, which you would be able to identify based on the curvature of the basement membrane. Here's a light microscopy of membranous nephropathy. What are we seeing here? Big, thick capillaries. Look at how thick these capillary walls are. And they're really staining red. They're eosinophilic. And there's a normal amount of cells here. And this is going to come into play when we contrast this with membranoproliferative nephropathy or glomerulonephritis. Here's another look at a membranous nephropathy. What do we see? Capillaries with some pretty thick walls to them. They're not thin. You see some thin walls, like here in the middle, there's some thin capillary walls. Here's a thin capillary wall. But then we're also seeing some very, very thick capillary walls, maybe off over here on the upper left. I'll use blue for the really thick ones, you know, like those are supposed to be capillary walls. That's the wall of a capillary. All of these capillaries are swollen. This one is too. And so normal number of cells, no sclerosis, just really thick membranes. So what does it have to be? Membranous nephropathy. Got some more looks at these subepithelial deposits. You trace your basement membrane, you look for the complexes. They're these dark electron dense regions. That's where the antigen antibody complexes are piling up. Where are they? On the inside or the outside? Well, here they're on the outside of the basement membrane. Relative to its curvature, they're sticking out of it. So we know that that's a subepithelial deposit that's right next to podocytes. And you might also see the spike patterned lamina densa get referred to in a membranous nephropathy. And the spikes are referring to areas of the basement membrane that, so the basement membrane kind of grows and grows and grows due to the immune complex damage. And where it's growing in between immune complexes, that's kind of the spikes that they're referring to. It's not really cut and paste visually. Another example of membranous nephropathy, you're going to find the basement membrane. Here it is. You notice it's got a slight downward curvature to it, and so you're going to say, here's our lumen down here. And then you're going to say, are the immune complexes above or below the basement membrane? And here they're clearly sticking out above the basement membrane, hence the epithelial deposits. So you get it. You got it. You're good. Membranous glomerulopathy, also called membranous nephropathy or membranous glomerulosclerosis, any of those things. It's just plain membranous. That's what you really need to know. That's what matters. Just plain membranous. So what does it look like? All glomeruli are involved. So this is diffuse, really. And there's no hypercellularity. And so that's important because that means it's not membranoproliferative glomerulonephritis. So how do you get this? You get exposed to an antigen and your body starts making antibodies against that antigen, and then they're going to complex with one another and float through the bloodstream and end up depositing in the kidney, where immune cells, namely neutrophils, are going to be magnetized and pulled in by the chemotactility of the IgG that's forming these antibody complexes, because IgG and IgM2 can activate complement, and complement 5A is chemotactic for neutrophils. So the neutrophils come in and they degranulate and spill ROS enzymes, and there's your kidney damage right there. That's the only way that the kidney's getting hurt in this type 3 hypersensitivity. Has really not a lot to do with the antigens, antibodies themselves. It's the immune response. So what are some antibody generators that could give you antibodies that would create immune complexes? A very common one is hepatitis B, and hepatitis C is more common in membranoproliferative on it. And so the way that you remember that is that proliferative is B, and then, or I'm sorry, membranous is B, and then membranoproliferative is C. And that's because membranoproliferative has got a little bit extra on it. And so you remember C's after B in the alphabet. And so just remember the longer word is next in sequential order. You could also get colon cancer. You could get carcinoembryonic antigen. It's got antibody generator in its name, and you could start making anti-CEA antibodies against that, and those could complex and give you this type 3 hypersensitivity in the kidney. Same for a couple different lung cancers that tend to produce different tumor antigens. So how do we really want to diagnose this? Light microscopy does the job most of the time, again, because it's not proliferative. The membranes are thick. We can stain with a silver stain, which is going to color the basement membrane black. And this is a good example on the right side of this page. Where you don't see the GBM taking the black stain is where immune complexes have deposited. And so really on this leftmost strip of GBM, you can tell there's a lot of patchy black and white mixed together. And so that means there's a lot of immune complexes right there in that region particularly. And then again, we've got a normal degree of cellularity. You're not going to call that a proliferative or membranoproliferative glomerulonephritis. It's just plain membranous. That's what matters. So this page 3 of the SDL, what stands out? Subepithelial deposits is mentioned a couple times. There's a graphic about subendothelial or epithelial deposits. Understand where they are, that they're under podocytes. You might get told that in words. You might get shown that. Subepithelial, 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 subepithelial. They really want you to know that membranous nephritis or glomerulopathy, membranous anything, has subepithelial deposits. And you are also going to see foot process effacement of podocytes in relation to these deposits. And when you see the word effacement, you might not know what that word means. I don't exactly use it in my colloquial everyday conversation. What it means is fusion of podocytes. You look at these podocyte feet and it's one big foot whenever you go to look on it on electron microscopy. And really this is kind of non-specific. We associate it most with minimal change disease, but you'll see it in most nephrotic syndromes. Just understand that you see foot process effacement, podocyte fusion in a kid, it's probably minimal change disease. So we said it's a type 3 hypersensitivity, and immune complexes can form in the bloodstream. That's the circulating immune complexes, example number 2 right there. Or they can form in situ, which means in tissue or locally. And so if they form in the tissue, then they're going to, again, because these antigens are IgG typically, they're going to activate complement, and complement is going to swarm to the area and do some damage to podocytes. And podocytes are responsible for producing the glomerular basement membrane. So when you damage them, you get a proteinuria because the membrane becomes really, really permeable. So that's the gist of it. It's a type 3 hypersensitivity and it activates complement. That's really what they want you to know. How do these patients present? They've got nephrotic syndrome, which means they're over 3.5 grams per day proteinuria. And they've also got a hyperlipidemia, maybe a lipiduria, and they're probably going to have a pitting edema, which means that around their eyes or maybe down around their feet, you're going to push your thumbs in and your thumbprints are going to stay in the patient because they have no oncotic pressure because they're peeing out all this protein. So membranous nephropathy tends to be pretty bad with a poor prognosis, and patients are going to need transplant if they can't achieve spontaneous remission quickly. Minimal change disease is another nephrotic syndrome. And remember here, I said in the last SDL video that I've got nephritic. Every time I highlight through my notes, I highlight nephritic with a pink highlighter. And that's because every time I highlight nephrotic, I do it with a blue highlighter. And so when I think, okay, gee, is this a nephritic or a nephrotic syndrome? You know, all the nephritic stuff is in pink in my notes and all the nephrotics in blue. So I kind of recommend you do the same so that you can keep them both separated if you're having a trouble with it. Nephrotic syndrome in children, it's called minimal change disease. And it's called minimal change disease because it's normal by light microscopy. Again, we look at this thing and we're like, well, there is basically no change in this glomerulus. But when you throw it under an electron microscope, you're going to see fused podocyte foot processes. Exactly the same thing that we just saw with membranous. So fused podocytes, what's that mean? It means we've got a nephrotic syndrome. And you give these kids corticosteroids and they tend to quicken up pretty soon. 90% of cases of minimal change disease are idiopathic. We think that there's some T cell response involved, and T cells are going to get triggered by maybe a drug or a particular allergen. They could get sensitized and then re-exposed to something, and they'll start making a lot of cytokines like IL-12, 13, 6, and that's going to agitate nearby podocytes and cause those podocytes to kind of swell up and get a little bit inflamed, and that's going to result in the fusion of the podocyte feet that you see characteristically on the subepithelial side of the glomerular basement membrane in minimal change disease. So how do we know we're on the subepithelial side? Trace your GBM. Everything on the inside of the GBM is your endothelial side or the capillary side. And then everything on the outside of the GBM is going to be your podocyte side or your subepithelial side. No glomerular lesions are seen by light microscopy. Effacement of foot processes of the podocytes, otherwise known as fusion. And here it is. Love it. Foot processes retract into cell bodies, not actually fusion. Yeah, okay, sure. Fusion. Got it. So pathogenesis, don't really need to know much about this. Understand there's T cells that make cytokines that hurt podocytes, and so you lose the basement membrane. And there's going to be podocyte damage in almost every sort of basement membrane loss. And remember that the degree of damage to the basement membrane is also going to correlate to the degree of proteinuria, which is why nephrotic syndromes have worse podocyte damage, more podocyte involvement, worse basement membrane damage than nephritic syndromes. We think that the molecule that gets T cells popping off initially might be this angiopoietin-like 4, which is a glycoprotein made by podocytes, which would explain why T cells would localize really close to podocytes before they started to produce all these injurious cytokines. How do these patients present? They're kids. Remember, they're kids. Most common cause of nephrotic syndrome in kids. So you can close your eyes and you got nephrotic syndrome. You know it all. It's over 3.5 grams a day proteinuria. You got a hyperlipidemia. You got pitting edema. Might even have anasarca. What's that? That's when you've got edema all over your body, very diffusely. So minimal change disease is also called lipoid nephrosis. You might, if you ever see lipoid nephrosis, minimal change disease. And it's lipoid because these patients are peeing out lipids. So the proteinuria is selective in minimal change disease. And what that means is that only small proteins get through. And then the SDL mentions that in membranous nephropathy and in focal segmental glomerulosclerosis, the proteinuria is non-selective, which means that in these two diseases, you can infer that there's a higher degree of glomerular basement membrane damage, so larger proteins are going to be able to pass through those larger holes in the membrane. Corticosteroids, again, snap of the fingers, tends to be pretty good. Let's talk about focal segmental glomerulosclerosis. Let's break down what that means. Focal. Some glomeruli are injured, but not all glomeruli. You take a kidney biopsy, you're going to see some healthy glomeruli. Segmental, what does that mean? Within each glomerulus that you look at on light microscopy, some parts of the glomerulus are hurt and other parts aren't. So this is an important disease because it's bad, it goes downhill pretty fast, and it also accounts for the most common cause of nephrotic syndrome in HIV/AIDS patients. So I suppose let's take a look at this first. Let's talk about minimal change disease. That's the same pictures as in the SDL. Here's another picture showing you the same thing. There's our basement membrane with fused podocyte feet. They're not really fused. Yeah, they're fused. They're fused. Okay, so focal segmental glomerulosclerosis. Number one, not every glomerulus is hurt. Number two, within a glomerulus, part of it's damaged and part of it's healthy. So looking at here, this part of the glomerulus is pretty sclerotic. This part over here at the base is pretty sclerotic. You get up and over here, this part's pretty sclerotic. But then the distal or urinary polar side of this glomerulus is actually relatively normal. You see some slight membranous type of change, maybe some slight segmentation, but there's some really normal capillaries that I just outlined in green there. Another example, in blue, let's highlight the sclerotic damage. Really, it's going to go like right through here is where I'm seeing a ton, but then especially this kind of quadrant of the glomerulus over here is looking much less sclerotic than the thickened part near the capillary pole over on the left of this image. Here's another good example. In blue here, you can see a very clear strip of densely eosinophilic sclerosis. And it's eosinophilic because there's just a lot of proteins in all these injured cells, and cells upregulate proteins when they're hurt. They're trying to make and repair. And then number two, there's extracellular proteins too, as cells tend to throw down like collagen and other constituents of extracellular matrix in response to damage. So there's your glomerulosclerosis there in the middle. There's your sclerotic lesion, but this is segmental because you've got large parts of this glomerulus that are entirely normal capillary-wise. Got another picture here. This is the collapsing variant that you see in HIV. And so it's collapsing. What's collapsing? Well, the capillaries inside the glomerulus. So everything outlined in black on this special Jones stain is capillaries. So let's trace it all the way around. Your glomerular capillary should expand to almost fill up the entirety of Bowman's capsule. But you can see that in this collapsing variant, the capillary has crumpled inwards, kind of like if you've got an inflatable Santa Claus in your front yard and then you pull the plug on it and it just kind of deflates. That's what this capillary bed is doing. It used to be blown up, but now it's deflating and it's collapsing on itself. And so all of the cells around the collapsed capillary, those are epithelial cells. Those are epithelial cells that typically line Bowman's capsule, but they're proliferating in response to the damage. Another really good example here. Yeah, this is exactly what it is, yo. The capillary bed of the glomerulus collapses. Again, think balloon that gets deflated. And so what I've just outlined in green here, that's the capillary bed. And you go back and you look at a normal glomerulus, or at least a semi-normal, and you know the capillary bed should be taking up almost the entirety of that Bowman's capsule. But we go back down and we look at this, and I mean, it's barely taking up half of it. And so the rest of Bowman's capsule is filled with proliferating epithelial cells and immune debris, and some frank necrosis too. And so this is a very bad disease because what do you think is the GFR blood going through there? Nothing, you know, like zero. Another look at it here. This is the collapsing variant again. You've got a little bit of glomerular capillary left. I'm outlining it in green. But then you've got around it a bunch of nothing at all. Just epithelial cells, necrotic cells, maybe a few immune cells like macrophages, but that capillary has started to deflate and collapse. So that's what focal segmental glomerulosclerosis looks like. Again, you need to know it because it's the AIDS one. And when we're describing it, remember, we just looked at minimal change disease, and what was the characteristic of it? Podocyte foot process effacement, podocyte fusion. And so you see the exact same thing here in focal segmental glomerulosclerosis because it's also a nephrotic syndrome. And so you know that there's a high degree of podocyte damage to get a correspondingly high degree of proteinuria. And so I would summarize this by saying that focal segmental glomerulosclerosis is going to present identically to minimal change disease with the nephrotic syndrome and the podocyte effacement. You just have a different light microscopic perspective. I thought this was a good paragraph here. I'll just straight read it. As the glomerular capillary tuft hypertrophies in response to the reduced number of functioning nephrons, podocytes hypertrophy, but they are unable to proliferate in response to functional overload. So this paragraph is referring to, it's asking and answering a question. And the question it's asking and answering is, when you have glomerular damage, what happens to the remaining healthy glomeruli? And so the answer is they hypertrophy because there are a bunch of endothelial cells and epithelial cells. They can do that, but not podocytes because podocytes are terminally differentiated. And so when the remaining healthy glomeruli hypertrophy, podocyte cell bodies are forced to stretch to cover a much larger surface area and serve many more glomerular capillaries, which are hypertrophy. hypertrophic podocytes become attenuated into cytoplasmic sheets as their primary processes thin out and extend. Ultimately, podocytes detach and undergo apoptosis. The denuded patches of glomerular basement membrane form the nidus for lesions of segmental sclerosis to develop. And so that's how you're getting the sclerosis. The podocytes go away, and then the capillaries that no longer have podocytes on top of them sclerose because they're trying to protect themselves from the inevitable damage. The juxtamedullary region of the glomerulus is where this pattern of damage starts, and so that's the urinary pole. Juxtamedullary, remember you've got a cortex and a medulla to your kidney, and juxtaglomerular apparatus, that's at the capillary side of things, remember, in between the afferent and efferent arterioles. But then juxtamedullary is referring to the opposite side of the glomerulus, where the urinary pole is, where the proximal convoluted tubule begins. So 3 good images here showing you increased mesangial matrix with obliteration of the capillary lumen. That's your sclerosis there, the obliteration of the lumen. And again, focal segmental, not the whole glomerulus is affected. You've got a classic variant, which is really shown top right here. You've got a perihilar variant, which is going to start around the hilum of the kidneys. Remember, your kidneys, the hilum, just like the hilum of your lungs, is going to be where the renal pelvis initially turns into the ureter. That's the hilum of the kidney. So if you start seeing glomerular lesions around there, that's your perihilar variant. Tip lesion means that instead of being at the urinary pole of the glomerulus, the damage is all at the capillary pole of the glomerulus. You won't get asked about that. You won't get asked about the hypercellular variant involving at least 25%, because how the hell are you going to tell if it's 25 or 30%, or 20%? You won't get asked about that. What you're going to get asked about is the collapsing variant, because that's the variant you see in HIV and AIDS patients when they get a glomerulonephritis. So electron microscopy, podocyte fusion, we've seen it before. Clinically, what do you see? Minimal change disease, but in adults, basically classic nephrotic syndrome. They're over 3 grams a day proteinuria. They're really swollen because they're losing protein. They're hyperlipidemic. Frequently, the onset of edema follows a recent upper respiratory tract infection, but I've noticed that a great many of these kidney diseases are subsequent to URIs, and so don't go around trying to memorize which ones come after an antecedent URI, because it's just stick and move, like you don't have to memorize that. Hematuria occurs in over half of these focal segmental glomerulosclerosis patients. So just because you have a nephrotic syndrome doesn't mean you can't have hematuria, even though that's a nephritic syndrome, what classically associated with, still have hematuria. Nothing says you can't. Hypertension, same thing there. And what we're making the nephrotic versus nephritic judgment call on is proteinuria per day in grams. So this is a bad disease, this sclerotic glomerulosclerosis. And the reason it's bad is because we just said that in order to even get the disease, your podocytes have to completely die and fall off, and so you don't have any podocytes left, you don't have any basement membrane left. That thing's not coming back. You need a transplant. HIV-associated nephropathy, understand it's the glomerulosclerosis collapsing variant, and you're going to see some cystic tubular damage as well. So understand we've got a glomerulus and then we've got a renal tubule, and combined they make the nephron. And so if you don't have glomerular injury, you got tubular injury. And so cystic tubules that get swollen with protein. Why would they get swollen with protein? Because you don't have a basement membrane. You don't have a basement membrane at all, so all that protein goes straight into the tubule. It clumps, it aggregates. Proteinaceous casts. Should make a lot of sense. Characteristic of HIV/AIDS infection. If you get an HIV patient and they got a kidney disease, it's probably this, straight up. You could see tubulo-reticular inclusions within endothelial cells, but that is only brought up one time and there's no picture. I don't think it's high yield. Okay, membranoproliferative glomerulonephritis. So we had membranous nephropathy. This is membranoproliferative. It's older brother here, okay. So the membranous part, what's that mean? Big, thick membranes everywhere. The proliferative part, what's that mean? Hypercellularity means that if you were to count every single cell in one glomerulus affected, you'd probably see more than 100 nuclei. And what's particularly the cell that's proliferating in this membranoproliferative glomerulonephritis? Good question. It's the mesangial cell, which is kind of the interstitial cell of the kidney, in between capillary endotheliums. So you've got a type 1, 2, and 3 of this membranoproliferative glomerulonephritis. I'd probably say that that's their order of importance too. Got to know type 1, type 2 be aware of as well. Type 3 is just the one that's not type 1 or type 2. This is a disease of young persons, children, and young adults. Going straight to the pathogenesis because that's what's going to help us tell these things apart. Type 1 and type 3 have the same pattern in that it's a type 3 hypersensitivity. And you know it's a type 3 hypersensitivity because you're going to see immunoglobulins and complement whenever you stain it. But type 2, here's the rub. You only see complement. You don't see any Ig when you immunostain. So is this a type 3 hypersensitivity? No. It's probably a type 2 hypersensitivity, a complement-dependent hypersensitivity. So perfect for us because it overlaps. Type 2 hypersensitivity. So what do these look like? Again, they're membranoproliferative. You see a lot of membranes and you see a lot of cells. There are a ton of cells in this glomerulus here. And check out this double tracking glomerular basement membrane that I've highlighted in the rightmost picture. That's the tram track appearance or double contour appearance. And it's called tram track. Like think about railroad tracks. You know, you got two tracks that just go like that. That's what these endothelial cells or the basement membrane is going to look like. So the basement membrane has essentially doubled itself because mesangial cells have slid in between endothelial cells in the basement membrane, or I'm sorry, in between podocytes in the basement membrane. And the podocytes just say, oh, who's this dude in the way? And they just make another basement membrane. So again, it's mesangial cells that are duplicating and dividing. You could see some leukocytes, white blood cells in there as well. And again, the interposition of mesangial cells is what's going to lead to the doubling of basement membranes by podocytes. You're going to see subendothelial immune complex deposits. So let's think through here. If you've got a lumen right here for your glomerular capillary, is subendothelial going to be on the inside or outside of that lumen? Hope you said inside. Inside is an endothelium, as in under the basement membrane. That's where we're going to see these immune complexes. So, what subtypes of membranoproliferative glomerulonephritis are you going to see subendothelial immune complexes in? Probably type 1 and type 3, because type 2 is not an immune complex disease. It's just purely complement mediated. You're going to have a different staining pattern for type 1 versus type 2. This is important. When you look at the basement membrane in membranoproliferative glomerulonephritis, type 1 has patchy electron-dense immune deposits, whereas type 2 has linear and continuous immune infiltration or destruction, rather, of the basement membrane. So type 1, again, you get those subendothelial deposits. Type 2 is also called C3 dense deposit disease. And you get continuous staining on electron microscopy. And then type 3, the only real thing you want to know about that is that you see subendothelial and subepithelial deposits. But other than that, type 3 is basically type 1. So I want to talk about type 2 right quick. The reason you would have only complement and not immune complexes involved is because this type 2 membranoproliferative glomerulonephritis is actually an autoimmunity against C3 convertase of the complement pathway. And so C3 convertase is what gets C3 going into C5, and then 5 goes into the membrane attack complex. So if you have a lot of C3 convertase, then you've got a lot of complement activation. So that's the mechanism of the damage. Hypocomplementemia, low complement in the blood. Why? You're using it all. On what? The basement membrane. So that's type 2, the complement one. You remember that, then you learn type 1, then you learn type 3 is the one that's neither. These are important photos here, I want to say, because again, you've got kind of patchier, granular type of deposits when you immunostain for IgG. And then you know that type 2 is not going to stain for IgG. It's only going to stain for complement. And it's going to have a linear pattern, as you would see here. You know, that's not bumpy, that's linear. And so it's also called dense deposit disease. And dense deposit disease on electron microscopy. I feel like they're going to give you something else to be able to make the diagnosis besides just based off EM. So what predisposes you to membranoproliferative glomerulonephritis? Hep C is a good answer. More often than B, hepatitis C wants to give you a membranoproliferative glomerulonephritis as opposed to B, which likes to give you a membranous nephropathy. So B is before C, membranous is before membranoproliferative. And also if you have an autoimmunity, that could be a potential source of antigen for you to start making antibodies that are going to later go into the glomerulus, give you that IgG reaction. So how do these patients present? Well, you could have a little nephrotic, you could be a little nephritic. Remember, a nephritic syndrome can turn into a nephrotic syndrome, and we're making the call based on grams per day proteinuria. If it's over 3.5, we're calling it nephrotic. If it's under, we're calling it nephritic. Nephrotic, you also see hyperlipidemia and pitting edema. Nephritic, you also see hematuria and hypertension. So not bad, not bad. No type 1, no type 2. Understand what they look like, and you got it. So some pictures of membranoproliferative glomerulonephritis. Membrano, look at all of this big thick membrane here. Hey, proliferative, look how many cells are in here compared to a normal capillary or a glomerulus. So there's too many cells in here. And so I'm about to compare this to a membranous nephropathy for you. Here's membranous. Here's membranoproliferative. There's membranous again. And here's membranoproliferative. There's just a denser cellularity in the proliferative variant that I hope you're able to kind of catch or judge or gauge for yourself. Here's another example of membranoproliferative. Do you see big, thick membranes in between cells? Absolutely, yo. It's like there's so much swelling in here. And what cell types are proliferating here? Mesangial cells. And so, yeah, that checks out. That's exactly what this looks like to me. And then proliferative. A ton of cells. Way too many cells. Compare that to just purely membranous. A normal amount of glomerular cells there. Here's another subendothelial deposit. Again, find your basement membrane, trace it. What side's out, what side's in. If the deposit's pointing inwards, it's subendothelial. So IgA nephropathy, also called Berger disease. What's happening here is an abnormal IgA gets stuck in the glomerulus, and then you start making IgG against that abnormal IgA that won't go away. And so this is a type 3 hypersensitivity because IgG is your antibody and IgA, in this case, is your antigen. And so you're going to detect this just by IgA immunohistochemistry, and if they give you that, it's cash money diagnosis. Hematuria is the big symptom. It gets worse after a respiratory or GI infection, and the reason being is because whenever one of those two parts of the body gets infected, you start popping out more IgA. But the problem in this disease is the structure of IgA is such to where this, what's it called? Deficiently galactosylated IgA is going to be less soluble than normal proper IgA. And so because it's less soluble, when IgA floats around in your blood, gets around to your kidneys, and it's time to push it across the basement membrane, normal IgA goes through. But this dude who is improperly galactosylated is just not going to go through the basement membrane. He gets stuck because he's stiff. So he stacks up. IgG recognizes there's a ton of IgA over here. IgG binds. You get complement that binds to IgG. IgG can bind immune cells directly through the Fc receptor. There's your immune-mediated damage in the IgA nephropathy. Most cases are idiopathic. We think that you've got a respiratory tract infection, CMV, Haemophilus, real common, IgA and Haemophilus, yeah. Staph aureus, toxoplasmosis, no rhyme or reason really. And this nephropathy is not really due to, it's no molecular mimicry. It's no, we're not making antigens against a bacteria. We're making antigens against this really dumb IgA. And so it's a structural IgA problem. That's the main etiology of this disease. You can see liver disease because the liver is a reticuloendothelial organ. And again, these IgAs that are broken aren't soluble and they're not properly galactosylated. I'll keep saying that because the word is probably going to be in a test question. So it's abnormally galactosylated IgA1 that bugs up your liver, your kidneys, and your spleen. Might occur in patients with celiac disease. And again, you also see it in the seronegative spondyloarthropathies. How do we diagnose it? Immunofluorescence for IgA. Electron microscopy shows a lot of mesangial proliferation. Again, this is a type 3 hypersensitivity. It's not against a bug. It's not against a drug. It's against a bad IgA. And you don't make this diagnosis via light microscopy, period. And so patients present with really blood red urine and not much else to say about it. It tends to go away spontaneously, and you're just going to manage their symptoms with a drug like an ACE inhibitor to get some pressure and work off of their kidneys and let them recuperate. So that's our second of 2 glomerular diseases, SDLs. I hope you enjoyed it. Keep studying hard, and let's secure this A bag.